forward starting now, but I'd rather you just listen and think it through and make sure that you're clear on what I'm saying. And if you're not clear, say, what do you mean? So that, we're going to make it very easy. But we're talking about, no disrespect to any of you, but we're talking about the most beautiful system in the body. And it's something that it makes a lot of sense. And when you start to figure things out and then you take them back and test them in the lab, like, it's really exciting, and you get to really have an impact on people's lives in a way that, again, I don't mean it in any way to say anything negative about musculoskeletal. I don't know anything about musculoskeletal care. So, the idea is that, but for me, obviously, I find it interesting. I find it fascinating. I've made my life and my career around it. The last 30 seconds of background, when I was in school and I learned about cardiopulmonary physical therapy, it was taught by a pediatric specialist who had never taught it before. And we believed that cardiopulmonary physical therapy was the Harvard step test and chest PT. And that's essentially what we learned. And depending upon what school you went to and who happened to be your cardiopulmonary teacher, maybe they had zero experience, maybe they had 50 years ago. Like if you went to, a school in Chicago and you happen to have Donna Fraunfelter, then you came out thinking that the body is there just to kind of support the heart and lungs. But I also know that in some schools it's just not there because there's not too many people who actually do it. So we have how many, I don't know how much our waiting list is up to now, but I know it's somewhere in the neighborhood of 60 or 65 patients waiting to come in for cardiopulmonary. That's not COVID, okay? So the point is, if you like this, if it's something you find interesting, if it's something that, you start to develop a flavor for, the patients are waiting there for you and your schedule will be full first week. So, but we want to make sure that we leave this, to people who are going to respect it and who are going to love it and who are really going to see it as something where, like, it's a mission, it's a calling, and it's, it doesn't get more basic than breathing and heart beating. So without further ado, I will start it up. Again, if you have questions, by all means, please, by all means, just shoot them out there. So, all right. So some of this stuff is pretty basic, and we'll start basic, but essentially for me, it all starts with risk stratification. And that means if I'm on the bus, I'm looking at around the bus to see where are the doors, what windows might open if some shit goes down on this bus, who on this bus looks like they're the most likely to pass out and or have a heart attack. When I go on a boat and I go scuba diving, I say, who looks like they're most likely to have a problem underwater? The most important thing is being prepared for something and knowing that if something goes wrong, you can actually handle it. Not like somebody hits the deck and then we go, wait a second, what button were we supposed to press again? So risk stratification starts really in the first visit, and if possible, before you see the patient. So primum non nocere, this is the first rule of medicine, which is Latin for first do no harm, right? So theoretically, I'm sure you can all think about some situations in which a patient can come in and we could actually hurt them, right? Where, physically hurt them or overdo it with them or not recognize certain signs or symptoms, and the patient could actually get hurt and be at greater risk doing what we do with them as compared to sitting at home in their recliner. So the first and foremost is, if we're going to take responsibility for patients, that means we have to be sure we can take them up in the air like a pilot, fly them somewhere, and then land them successfully. Now, that being said, in what we do, there's an average of probably 3 deaths per every 10,000 exercise testing sessions. And in our 100,000 sessions, thank the Lord, we've never lost a patient. And I think that that has to do with the care that we put into it. But that being said, you could do every single thing 100% correctly. Sometimes if you get the wrong patient on the wrong day, it doesn't matter what you do, you're going to have a situation. And recognizing this, I became an EMT in New York City to practice running codes, because it's a lot different doing it on a human being than doing it on a dummy. And, so I've got kind of a different slant on it too, which is being able to smell You know, we want to be able to smell when something's not right. You know, patient tells you a story, you say, you know, I come in for back pain, and they say, well, you know, when I start to walk up a flight of stairs, that's when my back starts to hurt. But they say, well, where does it hurt? And they say, well, it's in my shoulder blade, and then it comes around to my neck and my jaw, right? That's not back pain. And there are certain things that should be like a red flag. And especially when patients have risk factors, age, you know, smokers, obesity, diabetes, hypertension, you know, high cholesterol, things of that nature, family history. You could have a young patient, you could have a 47-year-old patient whose father died when he was 48. So when you're getting this information from people, keep in mind that what we're trying to do is we're trying to unlock this puzzle, and we're trying to unwrap this patient's medical history without hurting them, and making sure that coming to physical therapy is not going to be something that puts them in harm's way. When it comes to cardiac risk stratification, these are the things that I worry about most: coronary insufficiency, heart failure, and arrhythmia. And the reason why these things are so important are because these are the things that are going to be potentially lethal to your patient. So these are the things, you know, like high blood pressure, yeah, it's a situation. High cholesterol, it's a situation. But it's not like high cholesterol is going to rise up later today because of that steak you ate and kill you. These are the things that could kill your patient in a very, you know, expedient manner. And, you know, it's like they say, like Robert De Niro was an overnight success after Taxi Driver when he was waiting tables for 15 years about that, or, you know, before that. And it's the same kind of thing with heart disease, where you could say, well, it came out of nowhere. But if you look back on the last 15 years, you say, well, I have been gaining weight. Well, my cholesterol has been creeping up there. My pressure has been going up. I have become less active, et cetera, et cetera. And if you think about your patients who, let's say, take the subway to work, right? So the patient walks down 2 flights every day, and they walk up 2 flights to get to work. So that's 4 flights in the morning, 4 flights in the evening, 8 flights a day, 40 flights a week. That's 2,000 flights in a year. And if you think about it, if your patient, let's say their hip's gotten so bad that they can no longer take the subway, and now they take the bus, right? So now that patient's walking 4,000 less flights of stairs this year than they did last year. Think about the ramifications for that in terms of conditioning, in terms of heart conditioning, in terms of weight, in terms of shortness of breath, aerobic capacity, et cetera, et cetera, et cetera. So it really applies to everybody. And when you think about the heart, there are really 3 separate systems to the heart. There's the circulatory system, and this is where coronary insufficiency comes in. And when I talk about coronary insufficiency, I'm talking about blood flow to the heart, right? We're talking about blood flow through the coronary arteries that will provide oxygen to the myocardium, and that's the circulatory system of the heart. Then we have heart failure, and that's the mechanical system of the heart. And then we have arrhythmia, which is the electrical system of the heart. But if you think about it, coronary insufficiency, meaning that if the left ventricle is not getting enough blood because the LAD and the circumflex are not able to deliver enough blood, well, that could lead to heart failure, right? And if the right coronary artery is blocked and the SA node is not getting enough blood, well, that could lead to arrhythmia, right? Arrhythmia could lead to coronary insufficiency. How? Because if your heart is beating so fast and there's no filling, well, there's no blood moving forward to perfuse the heart. Arrhythmia can lead to heart failure, right? And heart failure can lead to coronary insufficiency and dysrhythmia. And this is one of the beautiful things about the system, is that it really makes sense. And the reason why I like treating medical patients and cardiac patients and pulmonary patients as compared to musculoskeletal or trauma patients is because in trauma, anything can happen, right? So it's like, I used to have a partner on my ambulance where I would do all the medical cases, he would do all the trauma, because I don't want somebody who got hit by a truck who everything is broken, okay? But this system is a really orderly, organized system, and that goes in both directions. It can get bad in an organized way, meaning if you engage in behaviors that aren't good, then it can get bad in an organized way. But then if you start to make changes in lifestyle, you lose weight, you watch your blood sugar, you lower your cholesterol, you lower your blood pressure, you quit that job that was driving you crazy, not H&D, of course, then you can start to spiral uphill in the same way. Questions or comments so far? All right. So the cardiovascular system. So the cardiovascular system has two major functions. And if we say it the most simply, okay, it's to bring blood and it's to remove waste products. We could say the same thing about the musculoskeletal system. So when you have a patient who's got, you know, a situation where we have pain spasm, you know, pain spasm cycle, well, guess what? They're not getting the oxygen and they're not removing the waste product. But if you have a pain spasm cycle in your low back, that's not going to kill you. If you have a pain spasm cycle in your heart, that's a little bit more significant. But in a nutshell, deliver O2, bring oxygen, remove CO2, remove acid, normalize pH, et cetera, et cetera, et cetera. The heart is a hollow muscular pump, okay? And the circulatory system, large and small elastic vessels transport blood throughout the body. You have to think of this as one system, right? So it's almost like this big circuit of water balloons that are there, and you have one pump at the end. Or if you think about an aquarium, you have this big pump, and the pump basically brings good water back, and it brings shoots good water out, and it brings bad water back, and it filters it. That's what the heart does, and the cardiovascular system. But as opposed to one pump, a hollow muscular pump, everybody thinks that the heart is a hollow muscular pump. So that can almost sound like it's hollow and it's like one big chamber and it's just this pump that goes like this. But we know that if we go into, so it's not like a big studio apartment, it's actually like an apartment that's divided into different rooms, and each room has its own sort of doorway to open up, and the door goes this way and the flow is this way. And if you eat at a good coffee shop these days, you go in one side, you get your food, you go out the other side, and the heart is the very same way. And more than a hollow muscular pump, I really like to think of the heart as two pumps. Okay, so it's a right heart and a left heart. This is just obvious. So everything here red is oxygenated blood. So these are arteries. This is our aorta, and we're coming down here. Arteries, the aorta is the largest artery in the body. Obviously, it becomes arteries, arterioles, capillaries, and that's where things start to move direction. And we have venules and veins, and then we go to the inferior vena cava from the lower half of the body and the superior vena cava from the upper half of the body, and that's how things go. So here we go. Central organ of the cardiovascular system. It's located between the lungs in the middle of the chest, 2/3 to the left of the sternum, 1/3 to the right. And the average size of the heart is about the size of 1 to 2 clenched fists. So the easiest way, if you want to know where your heart is if you use some Game of Thrones, you know, sort of body language and just go like this. This is, if you take your right hand and put it up here, this is where the heart is going to sit. So I told you it's 2/3 to the left of the sternum, 1/3 to the right. And the average heart is going to be about the size of 1 to 2 clenched fists. And that's for you. So your clenched fist. So not all of us have the same size clenched fist. So for example, Andre the Giant, if he were still alive, he would have a big clenched fist and a big heart. Donald Trump, well, forget Donald Trump. So that's a little bit, that may not play out in that case, but we always suspected that Donald Trump, sorry if there's any Republicans on this. I have to just let it rip when I do. But here's the heart, okay? Anyway, normal adult heart at rest pumps 5 liters of blood per minute, 1,900 to 21 gallons of blood per day. Don't memorize this stuff, okay? This stuff is not here for you to say, how many liters was that again? This is the stuff for you to say, wow, the heart works hard, right? And just to take in the information and be like, wow, this is an incredible thing that we have here. I want to draw parallels between the cardiovascular and pulmonary system as we go along, because if you think about this, it's like taking a Labrador and combining it with a poodle and you get like a Labradoodle. Similar type of thing here. So we have this pleura, right? We have, or rather the pericardium. So we have this pericardium, and we know that for most organs, we have a visceral pericardium, which is on the actual organ itself. And then we have a parietal pericardium, and in there is pericardial fluid. And the parallel between this and the lungs is that this is the pleura, right? So we have a visceral pleura that sits on the lung itself. We have a parietal pleura, and inside is pleural fluid. So inflammation can occur anywhere here, anywhere in the lungs as well. 3 layers: epicardium, myocardium, endocardium. So does this ring a bell? Anybody getting, you know, like some flashbacks to school when you were like, what is this? Epicardium sits on top of the heart. Myocardium is the muscle itself. That's the thick muscle that does all the work. And then the endocardium is basically inside, and that's where the blood will actually move through. The epicardium is also, in this case, the visceral layer of the pericardium. So that's going to sit right on the heart itself. The myocardium is the muscle. So myocardium, muscle, heart, specialized cardiac cells, and they have properties that other cells don't have. So first of all, we have electrical automaticity. And what that means is that if the heart were left to itself, it could still beat. Okay, so that's why, like, a lot of people have this idea that when you're defibrillating somebody, you're starting the heart, and it's actually the opposite. You're actually stopping the heart and then waiting for the heart's own automaticity to kick in. And the heart also has rhythmicity, and what that means is that there's going to be a set rhythm, there's going to be a set electrical cadence to the heart, and any part of the myocardium itself can trigger it, okay? So even if the very, very bottom of the heart, the apex, gets stimulated electrically, well, that's gonna send a wave of depolarization to the rest of the heart. The endocardium is what I said is inside of the heart. It's lined with a protective layer of cells so that it doesn't damage the blood. And this is kind of what we're looking at. So endocardium, pericardium, pericardial sac, this is the muscle tissue itself. Any questions so far? I also invite you to turn on your cameras so that I can see who is making faces and who is sweating and who's eating and who's not wearing pants, et cetera, et cetera. All right, so the heart is divided into 4 chambers, okay? And, you know, it's like when you had that thing in school that was kind of like a fortune teller. You folded up your paper. So there's 2 atria, which are the upper chambers of the heart, the right atrium, the left atrium. Together, they're called atria, and then we have the 2 ventricles. So the atria are really the receiving vessels. So blood is going to flow back into the atrium, and then they're separated by valves. And then we have the ventricles, and the ventricles are pumping, you know, the pumping chambers of the heart. Now, if we were just to talk about some of the things here, so we could say, okay, we could draw a line here and talk about the left side of the heart. And we could draw a line here and we could talk about the right side of the heart. So what are some, let's say, some similarities and differences, similarities and or differences between left and right side of the heart, just from a theoretical perspective? Does anyone, what would you say? So we hear about like left-sided heart failure, right-sided heart failure, right? We hear about valve replacements, aortic, mitral, pulmonic, tricuspid, right? So what would you say if a patient said, what's the difference between the left side of the heart and the right side of the heart? What would you think? And don't be afraid to be wrong here, okay? This is dusty for most people. So don't just talk it out. You know what I mean? Look at it. So look at the picture, look at it, and what are some differences you notice between the left side of the heart and the right side of the heart?
The left side is bigger.
The left side is bigger. So the left side is bigger, right? What else? Why do you think that is?
The left side is pumping oxygenated blood all over your body, and the right side is pumping the deoxygenated blood to your lungs to come back to your heart to then go to your body.
Right. So we have a ringer here. So the idea is it's not so much a difference between oxygenated versus deoxygenated, but the left side of the heart has to pump to every cell in our body, whereas the right side of the heart only has to pump a couple of inches, right? What else do we know? So those are two big ones, right? Those are two really important things. There's one more thing that's really important that I would say, and it's related to those two things. So if the left side of the heart is bigger and it has to pump more strongly, what else might you think about it? So it's also the high pressure side of the heart, right? So the left side of the heart is the high pressure side of the heart. The right side of the heart is the low pressure side of the heart. And the reason why that's significant is because there's different machinery, right? So like if you had a little Cessna plane, your motor would be very different, and the things that you need your plane to stand up to would be very different than if you were flying, let's say, the Concorde, right? So, for example, on the left side of the heart, we have high pressures, we have a larger chamber, we have more blood flow, and the other thing is that there's two valves on the left side of the heart. So, what are the two left-sided valves? How many people think mitral? Raise your hand. Okay, that's one of them. How many people think bicuspid? Raise your hand. So bicuspid is the same as the mitral. So if you raised your hand for mitral, then raise your hand again for bicuspid. And then the other one is the aortic, right? So blood essentially is going to come in here through the left atrium, and we know that it's coming back from the lungs, so it's full of oxygen. And we know that this is a system that's operated on pressure, right? So at this point, when blood starts coming through, we have this valve right here, which is the mitral valve, where the bicuspid valve is going to be open, and we're getting blood flowing through here. This right here is, I just pointed because I thought you guys could see me for a second, but this right here is our aortic valve, right? Because here's the aorta, right? So this is where blood's going to actually come through here and go up this aortic outflow tract. But what happens is when blood is flowing through here, then what happens is blood is flowing. And at a certain point, the pressure in the left ventricle is going to exceed pressure in the atrium. And when pressure in the left ventricle exceeds pressure in the atrium, guess what? Mitral valve closes, right? So now at that moment in time, or at that second in time, we now have both the mitral valve and the aortic valve are closed, right? And in fact, all the valves are closed back up to the right side of the heart. And then we're going to come back to this moment in time. So right side of the heart, low pressure side of the heart. And we know that from here, this is the superior vena cava. Blood is flowing from the upper part of the body, inferior vena cava. At the same time that blood is flowing from the atria to the ventricle on this side, it's also flowing from the atria to the ventricle on this side. And at this moment that the aortic valve is closed, the pulmonic valve is also closed. And the pulmonic valve is going to the pulmonary artery, right? And the lungs. So there's going to be a point in time where all four valves are closed, right? And it's like, there's that 1 second, all four valves are closed, and then something is going to happen in response to that. But here's how the mitral valves close, okay? Pressure in the left ventricle exceeds pressure in the left atrium, mitral valve closed. Pressure in the right ventricle exceeds pressure in the right atrium, and the tricuspid valve closed. If I say it together, pressure in the ventricles exceeds pressure in the atria, and there's a name for these two valves together. Does anyone know what it is? These are the valves that are in between the atrium and the ventricles, right? So the AV valves, right? So these are known as the AV valves. Anyone know what the two other valves are called? I'll give you a hint. They're kind of shaped like a half moon. So those are the semilunar valves, right? And that's another way to think about it. So we could think about, well, what's going on at the AV valves, right? Let's check what's going on between the atria and the ventricles, because when we start looking at EKGs, we're going to be looking at electrical activity that corresponds with this mechanical activity. Right now, we're talking about mechanics of the heart. And when I talked about mechanics before, we were talking about heart failure. So the thing to keep in mind is that this is like the flow of traffic where blood comes through here, pressure in the left atrium, left ventricle exceeds pressure in the atrium. This valve closes, right? And all the valves are closed. So now we have this time, everything's shut. Something exciting is about to happen. Does anybody know what it is? Okay, so at this moment in time, we're going to have a contraction of the ventricles, right? And the ventricles are going to contract, but the volume in the ventricles is not going to change, right? And that's why we call this the, if someone knows this, you get a free copy of my book. Anyone know this? So the volume in the ventricles remains the same, but the ventricles are contracting. That is called isovolumic or isovolumetric contraction, right? Because these ventricles are starting to contract, but they're closed. The mitral valve is closed. Here in the aortic valve is closed. So my left ventricle closed top and bottom unless something's wrong, right? So if the mitral valve is impaired, as in the example of mitral regurgitation, well, guess what? It might not be isovolumetric because we might actually have backflow into the left atrium, which is called mitral regurgitation. If there's a problem with the aortic valve, well, we might actually have blood escaping forward, and it may not close all the way. So it won't be isovolumetric. But under normal circumstances, we have this isovolumetric contraction of the ventricles. And when pressure in the ventricles exceeds, on the left side, pressure in the aorta, and on the right side, pressure in the pulmonary artery, well, then guess what? The semilunar valves open up, blood is ejected from the ventricles, and then on the flip side of it, when blood in the aorta when the pressure in the aorta exceeds the pressure in the left ventricle, guess what? That swings the aortic valve closed. And when blood in the pulmonary artery exceeds the pressure in the right ventricle, then that swings the pulmonic valve closed. And that's the cardiac cycle right there. Does that sound familiar? Is anybody's mind blown already? All right, it shouldn't be, okay? And the thing is that if you understand this and think about it and look at it rather than memorize it, you're going to be a lot happier and things will make sense to you. Because if we talk about this just from the heart perspective, right? Let's see some of the things that could go wrong here. So let's just talk about valves for a quick moment, okay? And if we don't get off this slide tonight, that's okay. But let's just talk about valves. Valves have two ways of going wrong, right? What are they? As an alternative, feel free to just stare back at me blankly. That's just as good because you know I'll ultimately give you the answer. But if you think about it, okay, who wants to?
Floppy.
They could be floppy, okay? So if they're floppy, what might be another word for that valve to be floppy? Because floppy, I would really refer to the ventricle, right? We'll talk about floppy later, but you're on the right track. So what's another way we could describe that?
Doesn't close completely.
Doesn't close completely. What'd you say, Tom?
That's what I was going to say.
So it doesn't close completely. So it's kind of like, it's what?
Prolapse.
Not prolapse.
Insufficient.
Insufficient, okay. MI, mitral insufficiency, not to be confused with myocardial infarction, right? But so if the mitral valve is insufficient, that's telling us that it doesn't close all the way, right? So what could happen? And when we think about the cardiac cycle, okay, think about systole and diastole, systole and diastole. Systole is when the heart is contracting, right? And diastole is when the heart is filling. And when we talk about the heart, we're really referring to the ventricle. So we're really talking about ventricular systole and ventricular diastole. So let's talk about the mitral valve, right? So the mitral valve can be insufficient. And if the mitral valve is insufficient, we could get the backflow of blood from the left ventricle into the left atrium, right? So I told you about this isovolumetric contraction where all 4 valves are supposed to be closed, but the mitral valve is insufficient. So when then that left ventricle contracts, blood goes back into the left atrium. Mitral insufficiency. Now, prolapse means when there's an actual problem with the valve itself and the valve itself goes back into the left atrium. Okay, so that's a structural problem as well. But think about it. Now, imagine that every time this heart, this left ventricle beats, blood is supposed to be going back. Blood is going back into the left atrium, right? But at the same time, blood is also coming forward into the left atrium from the pulmonary circulation again, because this is just like a conveyor belt where things are moving along, and then the next set of blood flow goes through, ba-boom, ba-boom, ba-boom. And now we have blood coming in 2 directions into the left atrium. And what can happen here? Does anybody know? We can have enlargement of the left atrium, right? Anyone know what that's called? Left atrial dilatation, right? And now let me even skip forward a little bit. So we're going to skip from here. We'll go back over here because we'll talk a little bit about how that mitral insufficiency may occur. Anyone know any causes of mitral insufficiency?
Calcification of the valve.
Could be. And calcification can also cause stenosis, right? It could be either one depending upon how it calcifies. What else? Okay, so what?
Are some people born with a genetic, I forgot what it's called, but they have a genetic insufficiency there?
You can. It can be. There are definitely congenital valve defects. But let's think about something else. Something as simple. And this is why you have to think about the end result, right? So you say, oh, I'm going to salt my food, right? But honey, you have high blood pressure. What is it going to do to me, right? High blood pressure is going to cause what we call an afterload, right? We have preload and afterload. Remember those things? So afterload means the pressure after the left ventricle, which means that if you have high systemic blood pressure, your left ventricle has to pump that much harder in order to overcome that resistance. The effect is the same if you have aortic stenosis, right? So stenosis is the opposite of insufficiency and regurgitation. So here's our aortic valve. So imagine that that guy is super tight. And now the left ventricle wants to pump blood through there, but no, it can't because it's tight, or the left ventricle has to pump harder. And when the left ventricle pumps harder, what happens to it? It gets thicker, right? And initially it gets stronger, and we wind up with what's called LVH, or left ventricular hypertrophy. And the thing about that is that maybe at the beginning it's not a problem, but if you think about it, a thicker myocardium, because that's what we're talking about, requires what? More oxygen, because this is all based on supply and demand. And we talked about the circulatory system before. So if you don't have good coronary arteries and you don't have enough blood flow going to that myocardium, that's where we have coronary ischemia. So now we have this hypertrophied left ventricle, and just a couple of points. The left ventricle hypertrophies laterally, right? Which is why when you look at a chest x-ray, we see this on a chest x-ray looking anterior to posterior or posterior to anterior, and it looks wider, okay? So imagine this left ventricle is now bigger, thicker, wider, and this mitral valve, which is sitting right over here, is now getting stretched, right? So it's like your socks that you loan to your big-footed friend. When you get them back, well, they don't quite fit the same, right? And it's the same kind of thing with the mitral valve, which is that after this ventricle has gotten so big, we don't actually get the same closure of the mitral valve. Now, let me just compare that for 1 second with the athlete's heart, okay? Because we know that athletes have big left ventricles, right? We know that runners have massive left ventricles, and that's considered to be a good thing, right? Does anyone know what the difference is between the scenario I just described of the patient with long-term hypertension versus an athlete? And let's say their ventricle, if we look at it on chest x-ray, their ventricles are identical size. But what's different?
The volume.
Volume. What do you mean by that? You don't think I'm just going to let you get away with volume?
So I can't remember but I think I remember that the volume inside the left ventricle also gets smaller as the wall gets thicker.
It can either get smaller or remain the same. Okay.
Okay.
So you're on the very, very right track. So if you think about supply and demand, right? And that's for the heart muscle itself as well as for the whole body. So the idea is that as that left ventricle hypertrophies and gets thicker, it requires more blood flow. But in that scenario, the chamber size does not increase. So the supply is the same. In an athlete, they have a big left ventricle, but instead of having that thick muscular wall, they have this big open left ventricular. Left ventricle, the chamber inside can accommodate increased volume, right? And there's a word that's LVEDP, which is left ventricular end diastolic. I'm not trying to say LGBTQ, I'm trying to say LVEDV, right? Which is left ventricular end diastolic volume, right? They had a big, strong protest before LGBTQ, and they were like, we need more volume. So the idea of that is that, remember Starling's law of the heart? Does that ring a bell? Anyone? So the Starling law of the heart is the greater the stretch initially, the greater contraction. And this is also going to relate to cardiac output, right? So anybody know the formula for cardiac output? Everyone's like, maybe if I look up enough, someone will answer and I won't. Go ahead. It's blank times blank equals cardiac output.
Heart rate times stroke volume?
Bingo! Michelle
Okay.
Triano, heart rate times stroke volume. So if you think about that, right, and we think about the athlete with a low heart rate, why do they have a low heart rate? It's because their stroke volume is massive because they have this high left ventricular end diastolic volume, right? And if we think about our patient who have, very small hearts or cardiomyopathy and they're not putting a lot of blood in, well, that's why they're going to have a very high heart rate. So that is very, very good. And it's very interesting. And now here's another beautiful parallel between the heart and the lungs. There's something called minute volume, okay? Minute volume is respiratory rate times tidal volume, okay? And the thing is that it's the same type of thing. So if you think about the patient who's got a fast respiratory rate, right? They're going to have a low volume of air. Or if they have a low volume of air, think about your patient with restrictive lung disease or obstructive lung disease who's not able to move a lot with their breath, right? So they have to breathe fast. The patient with a weak heart who's not able to push a lot of blood forward with their weak heart, well, they're going to have to beat a lot of times per minute. And there's a billion other factors that go into this, but we're talking now about mechanics. So we talked about a left ventricular hypertrophy. This mitral valve gets stretched. It becomes insufficient. We have mitral regurgitation. The left atrium then also becomes dilated, right? And we know that blood is entering the left atrium from where?
From the lungs.
From the lungs, the pulmonary circulation, right? The pulmonary veins. So we know that if this backs up, then this is going to wind up in the pulmonary circulation, right? And that's what we talk about when we talk about the beginning of heart failure, right? Left-sided heart failure. And if it continues, then where is it going to wind up? It's going to wind up in the right side of the heart, right? So if it continues back through the lungs, then it's going to go back through the pulmonary artery. It's going to go back to the right ventricle, back through the tricuspid valve, right atrium, and then it's going to go to the superior and inferior vena cava. And how's that going to show itself clinically? edema, right? So think about that. So when your patient comes in and for the first time, you know, you've been seeing them for 6 months and they've never had swollen feet, and today they come in and they're complaining of shortness of breath and they look pale and they're breathing fast and their feet are swollen. Well, we have to think that, hey, I know you came in for your back, but something might be going on here, right? And it's not enough to say, you know, like a lot of times I think as PT, we get this idea that like, well, we need to tell them to call their doctor, right? Or we need to say, call your doctor, ask them about this. But it's so much better if you get on the phone and you say, hey, guess what? This is Tom. And I noticed that, you know, this patient went out for dinner last night and she ate 36 fried dumplings and she's full of salt and her feet are swollen and she's short of breath. And I listened to her lungs and there's rails at both bases. Well, now you're talking and now you're telling the doctor something that they can use that might say, hey, send them to my office. Hey, send them to the emergency room. Hey, do this or that, the other thing. But if you're kind of like, if you say, well, what's their blood pressure? And you say, well, the blood pressure is 160/80. You say, well, what is it usually? And you go, I don't know. Again, everything is relative and things are trending, right? So I could look at your blood pressure and it could be 180/120 and you go, oh my God, that's terrible, right? That sounds terrible. But what you might not know is that maybe 10 minutes ago, it was 220/150, right? So in comparison, we're going in the right direction, in a better direction. It's not good to have 180/120, but my point is that every single patient that you see, you're taking responsibility for them. And at least the first few times you see them, start to track their vital signs so that you can at least look at trends and so that you know when something is different, because you don't always have to have a diagnosis. You're not going to diagnose the patient, but you have to be able to pick up when something's not quite right. Because if you go through your therapy and that patient has a serious problem there and they go to the hospital and they say, well, their legs are totally blown out. Why did you think it was a good idea for them to do therapy? And, you know, we, thank God, have never been sued, not malpractice. But the idea is that if you think about it from a legal perspective, and I don't worry about liability. I don't worry about somebody coming after me in court, but I think of it like this. I think about it, if I had to defend this in court, would I be able to make a strong case clinically for this? Like, do I know enough that I could run circles around everybody in that courtroom and nobody would be able to find anything I did wrong because they don't know what I know? Okay. And on the flip side of it, and look, we all make mistakes. I have 2 mistakes that I can recall that were, you know, kind of bigger mistakes than I'd like to say we happen, you know, but, you know, you say on the other side, if I were on the prosecution side, could I pick apart that case? And it's, you know, it's not to say we're afraid of litigation. I'm not, but it's a good way to kind of think, are you making good judgment calls? And a lot of times I'll be thinking of something and I'll say, I wonder what would happen if this happened right now. Would I be, you know, in trouble for it, or would I know what to do? And again, it's not like when the patient hits the deck that you want to start thinking to yourself, what was that, 15-2, 30-2? No, you want to prepare and run these scenarios over and over. And don't get me wrong, I'm not trying to just say it's all about emergencies, but the beauty of this is that when you understand this physiology, then you can change people's physiology for the better, right? You can start to if we know how blood pressure goes up, then we can bring blood pressure down. Right? If we know that constriction of the blood vessels is going to increase pressure, then we know that if we can somehow figure out a way to relax the blood vessels or relax the airways, that we can also bring that down. So we actually have a lot of control over the cardiovascular and pulmonary system, and we actually have a lot of control over the autonomic nervous system. And that's one of the reasons why, you know, we are able to kind of navigate certain things with COVID patients that, you know, we happen to be in a good position to do it because it's cardiovascular and it's pulmonary, but it's that autonomics. And we think of things in a little bit more of a concrete way. We don't think, okay, we're going to do a stretch now that's going to relax the smooth muscle inside your airways, but we can.
Uh-oh. Noah,
I think we lost him.
I think we lost him. First he froze.
You take over, Tom.
There might have been a time 20 years ago where I could have done some of this, but
I guess I go, oh yeah, I kind of remember
Yeah.
that. Sort of, yeah, not really.
Always a big Jenny.
Anybody have a do we have a contact number for him?
Well, isn't he the host? Wait, how did we all get on?
He
Is he the host?
Yeah.
I think it changed me to the host.
Oh, well, Michelle, then you keep going.
Yeah, no, can't do that. Can't do that.
7:57.
I have no idea.
Well, we lost him there, so he knows he's off. He's not, hopefully not still talking. Give him a minute to come back.
I don't think we should count on that.
Are we supposed to go to 8 or later?
I don't know that.
Okay, Noah's back.
Yeah.
Back, but looks like he's muted for the moment.
And he looks like a pair of lungs.
All right, I'm back. Sorry about that. My computer
Yay.
shut down. All right, so let me just go ahead a little bit. All right, so essentially what I'm trying to say here is that the ventricle bone is connected to the valve bone, which is connected to the atrium bone. And if you understand how all these things work, you can understand how they can go wrong, and you can understand how you can train them for better things. So just a kind of review here, and then I'm going to go to questions. Atria, thin-walled, upper, receiving chambers. So if we think about it, I told you before that the AV valves, whoops, you know what? I know I forgot to share. Hold on one second. All right, there we go. All right, can you see my screen? Okay, so here we go. So atria are thin-walled, and I told you before that the AV valves are open as blood flows through them. And the other thing about this is that at a certain point, and this is right before the AV valves close, there's going to be what's called the atrial kick, right? So we have atrial depolarization, atria contract, right? And that contraction is going to contribute about 15 to 35% to what's in the ventricles at the end of filling or at the end of diastole, which is what I told you before is LVEDV, left ventricular end diastolic volume. So if we look here, look at the difference in terms of atria. So it's about 3 times to double of the right versus left. And the ventricles are the pumping chambers. And these pressures are going to be, look at this, look at the difference here. And if we think about this 120/80, right, this is filling, this is 55 versus 8. So we know that the right side of the heart is really not designed for those high pressures. And so when we get things like pulmonary hypertension, either idiopathic or when we have patients who have severe lung disease for a long period of time, we can see increased pressures on the right side of the heart, and that's not really designed for that. Left ventricle is the main pumping chamber of the heart. It's responsible for delivering blood to the body. We said that walls can be greater than 1/2 inch thick, 2 to 3 times thicker than the right ventricle. The septum is in between, right? So we have an interventricular septum and we have an interatrial septum. And that's essentially, if you think about it, that's keeping oxygenated blood from deoxygenated blood, right? So if we had a hole in the ventricular septum or the interventricular septum, then we'd have a mixing of oxygenated and deoxygenated blood. And again, this is how I like to think about it, which is a right and left heart. So the right atrium and the right ventricle are the low pressure side of the heart. That's going to carry deoxygenated blood, and the oxygen saturation is going to be about 75%. Left side is high pressure. Oxygen should be greater than 95%. And that's what we're measuring when we're actually taking someone's oxygen saturation. So here's just a schematic of it. Left side of the heart, blood comes out of the aorta, goes to the body, arteries, arterioles, capillaries. This is where we start to turn from oxygenated to deoxygenated. We have capillaries, venules, goes back to the inferior vena cava from the lower part of the body, superior vena cava from the upper part of the body, and the carotid sinus from, the coronary sinus from the heart itself. And then we just continue, and it's a beautiful plumbing schematic. So blood is kept flowing in a forward direction by a series of 4 valves. We kind of talked about this a little bit, but they're going to prevent the blood from flowing backwards, and they'll open and close in response to pressure changes. So these are our AV valves. We talked about this. Mitral valve is on the left side of the heart, separates the left atrium from the left ventricle. Tricuspid separates the right atrium from the right ventricle, and these are the semilunar valves. So these are the aortic and pulmonic valves. Here we go again. And the valves contain leaflets. They open and close, pressure changes. And just a little quiz, mitral valve is located between the left atrium and the left ventricle. Tricuspid located between the right atrium and right ventricle. AV valves, thin but strong fibrous cords. Those are the chordae tendineae that are going to pull down and also go up again. And when the ventricles contract, these papillary muscles pull them down to prevent the leaflets from going through. And if that doesn't happen, and if the leaflets do go through, that's what we were talking about before when we said prolapse. It's when the AV valve leaflets go back into the atrium. There's that. Mitral valve, bicuspid valve, 2 mobile leaflets, tricuspid valve, 3 leaflets. And we talked about all this. And so again, I'll just end on one point, which is we'll end on the valves, and then next time we'll start with the blood supply of the heart, which is also very interesting. But if you think about it, and I'm going to talk now about the cardiac cycle again. So we have AV valves. On the left side of the heart, the AV valve is the mitral valve. On the right side of the heart is the tricuspid valve. And then we have our semilunar valves. On the left side, it's the aortic valve. And on the right side, it's the pulmonic valve. And if you think about it, if we were to draw kind of a graph now, right? And we had all the valves down the left side and all and we had on the right side, or on the top, the things that could go wrong. A valve can either be too loose or too tight, right? So if it's too loose, it's insufficient. If it's too tight, it's stenotic. And that's going to affect different cycles of the heart. And if you think about it, when doctors listen and they talk about murmurs, like you may hear the term systolic murmur or diastolic murmur. So if you think about it, right? If we talk about, let's say, the left, we could talk about functions, and it's going to be, when do we hear this murmur? So where is it going to be in the cardiac cycle? So in the cardiac cycle, when we listen to the heart, we hear lub dub, lub dub, lub dub, lub dub. Lub is S1. S1 is closure of the AV valves, right? So it's closure of mitral valve. That's when I told you the pressure in the ventricles exceeds pressure in the atrium and they close. And dub is closure of the AV valves, right? So anything that happens in between lub and dub is essentially a systolic murmur. Anything that occurs in between dub and lub is a diastolic murmur. So I told you that things can either be stenotic or they can be insufficient. So let's say mitral valve. So mitral valve, we could have mitral stenosis or mitral insufficiency. do you think that mitral stenosis is a systolic dysfunction, is a systolic disorder, or a diastolic disorder? Mitral stenosis. So I'm asking you, is there a problem with filling or a problem with pumping?
So it's diastolic.
It's
No.
a
Yeah, diastolic. Yeah.
Who said that? Who said that?
Tom.
Tom. Oh, you're not moving your lips, Tom.
I'm frozen.
You're frozen. All right. So here's the thing. So it's diastolic dysfunction, right? So mitral stenosis means that blood is not easily flowing from the left atrium into the left ventricle. So mitral stenosis is diastolic filling dysfunction, right? And that means automatically that mitral regurgitation or mitral insufficiency is going to be systolic dysfunction, right? Because when the left ventricle contracts, I think everybody's frozen now. Hopefully you can still hear me. But essentially when the left ventricle contracts, blood will flow back up into the left atrium, and that's systolic dysfunction. Is anybody still there?
Yes.
Awesome. Okay. So let's go to the aortic valve. So everyone's frozen on my screen, but let's go to the aortic valve. You could have two things. You could have aortic stenosis or aortic insufficiency. So aortic stenosis is the aortic valve is too tight. Is that systolic or diastolic dysfunction?
Systolic.
Systolic, because when we need to pump blood out of the left ventricle to the aorta, right, it's too tight. So we have systolic dysfunction. And what about aortic insufficiency? Is that systolic or diastolic?
Means it's not closing.
It's not closing when it's supposed to be closed, right? So that's going to be diastolic dysfunction. So there's no problem pushing the blood forward. It's staying closed so that the blood can't come back. And then if you flip it on the other side, so it's the same exact thing. And you can draw an actual graph and you'll know that it's the same thing for the AV valve. So when the AV valves are regurgitant, meaning
Uh-oh. Come back, Noah.
I think we have to do CPR on Noah.
It's his Wi-Fi that needs the CPR.
Hello, this is someone who's been listening from afar. Call me God, whatever.
Hi, Marion.
I'm doing my dishes while this is all going on. Anyway, Noah has texted me to tell you that he will be right back after a station identification. Are your hands cracked? Are you tired of doing dishes? Take a load off your feet. Turn on Zoom. Listen to Noah chat about the heart. But he will be back.
Is that Palmolive? You're soaking in it, man.
Yeah, I sort of like outed my age, huh?
Or I did.
all right, I'm back. So
They were dissing, they dissed you, Noah. They were dissing you.
I don't care. I don't care what they say about me. Anyway, so the idea is that, you know, you think about the point in the cardiac cycle, and then we think about exercise, right? Because we talked about supply and demand, and somebody may be perfectly fine at rest, but then they exercise and the demand goes way up, and there's that mismatch. So if you ever see your patient who is, you know, doing fine at rest, and then they're exercising and they're short of breath, or they have chest discomfort, And it is very possible that it's just deconditioning, okay? But it's also possible that it's something else. And if you know, a patient's reporting pressure in their chest, and you assume that, you know, it's probably, you know, gas, or it's that bean burrito that they ate from the truck outside at lunchtime, then it turns out to be their heart, then you've got a situation on your hands. If you assume it's the heart and it turns out to be that bean burrito they had at lunchtime, well, then it's a funny story to tell people. But the idea is that there's a holistic way to treat patients. And if we don't take vital signs, at least at the beginning, at least till we get a sense of the patient, then when something goes wrong, or if something goes wrong, then A, we have nothing to compare it to. And B, we may not realize that that problem that they're having, yeah, they're short of breath and we thought it was deconditioning, but certainly osteoarthritis can cause you to become less active and can cause you to be deconditioned, but so can the heart, right? The patient who's a 55-year-old Black man who's 50 pounds overweight, diabetic, hypertensive, and high cholesterol, and has a family history of heart disease, they may be coming in because they're there for prosthetic training, but that person probably also has some underlying heart disease. And my feeling is that if you have atherosclerosis in one area, you have atherosclerosis in the other. So I know this was a lot of information, like at one shot, especially if you haven't thought about this in a long time. But I'm just trying to kind of shake the rust off and plant the seeds that, you know, there's a lot going on besides just, you know, just maybe what the patient is there for. And how great would it be if, instead of missing something and then wondering what happened to our patient, if we know about these things and we can say, hey, you know what, something doesn't look right today. And you call your doctor and you say, hey, do you know that your patient blah, blah, blah? Or do you know that, you know, and also it has to do with knowing the medications, knowing how the medications will affect these things, et cetera, et cetera. And like I said, I've seen a bunch of patients. COVID's a whole different story. COVID, chest pain pre-COVID is not the same as chest pain post-COVID. Shortness of breath pre-COVID is not the same as shortness of breath. That's a whole other ball of wax. But you can't start talking about the abnormal abnormalities until we know the basics of basics. So questions, comments, feedback, anybody?
What is the makeup of the valves? Are they more like cartilage? Are they more like
Fibrous.
ligaments?
They're fibrocartilaginous. Yep.
Okay,
They're
so
connective
once they
tissue.
stretch, they stretch. They don't bounce back.
They don't bounce back.
They don't back. And what creates stenosis usually in the valves? What?
So it depends on the valve. So in mitral valves, a lot of patients, so mitral valve can occur by aging. So most people develop mitral valve dysfunction as they get older. If we see aortic valve dysfunction, not that it can't be like long-term hypertension, it can, but very often it's somebody who's got like rheumatic fever or some type of other post-viral decay of the valves. So questions, I mean, does any of this like resonate with any of your patients? Like, are you thinking of patients? I don't mean, do you remember it? I mean, you know, like it's okay if it's not at the tip of your tongue. I wouldn't expect it to be. But like, can you think of patients where like maybe on second look, you say, yeah, she was a little short of breath, or yeah, she was complaining of dizziness. You know, and you know, we have to consider like a differential diagnosis. Like if you want to learn a lot about medicine, I suggest binge watching House. That's where I learned most of what I know. But it's really the idea that you have to consider everything and rule things out as you go along before we assume you're wheezing, this person must have asthma. Because sometimes it is and sometimes it's not.
I did catch somebody's valve problem one time, actually. Yeah, and I ended up talking to the cardiologist and sent him there that day, just because he had been fine. And then we were warming up on the bike and he was out of breath and said, yeah, I've been out of breath a little bit, you know, but you know, I'm just kind of getting out of shape. And so I listened. So I took his blood pressure and I listened to his heart, and that's the one thing that I didn't do in the hospital was a cardiopulmonary rotation, but I could tell from listening to him that his valves weren't working well. So we stopped, and that was one time that I caught something.
And you
And it
might
was-
have saved that patient's life.
I did get him to go into a process. Eventually, he lost his life because of it, but
So you killed him.
I started.
Thanks a lot, Tom. Thanks a
Exactly.
lot.
That's
No.
why our numbers were down that week. Yeah.
No, listen, that's grotesque humor. I don't appreciate it. Anyway, no, it can happen. But you know what? You did the right thing. I mean, look, like I said, sometimes you could do everything right, but you know, the biggest thing is not necessarily to diagnose aortic stenosis or aortic insufficiency, but it's to be able to say, this is what it's supposed to be, and it's not, right? It's like an EKG. It's like, you don't have to know what the arrhythmia is, but if you know it's not normal sinus rhythm, then there's always someone around who can help you, right? And that's what we have to find. We have to just know something's not right here. And if something's not right, like if you get into your car and you're like, I hear something ticking from underneath, like get out of your car and run. Like, don't say, I'm going to try it anyway. You know, like you have to just be alert to the fact that, especially as we deal with older populations, especially now with COVID, because the little stuff is not getting looked at, right? The little stuff is not getting looked at. And so it's very possible that patients are going to come to you, you know, and some people would make the case that PTs are primary care providers. I don't believe that. But a lot of times we are going to see the patient a lot more than their doctors are. And we're in a great position to really look at trends, because a doctor is going to see a patient once every X number of weeks, months, years. Patient comes in, they're nervous, their blood pressure may be higher. They may get medicated based on that one blood pressure versus, like, especially with remote monitoring, like we have patients now who are monitoring, you know, spirometry remotely on a daily basis. And we're able to, you know, detect trends in people that would never get seen before. So, you know, it's really, I mean, obviously I'm biased. I think it's super fascinating. And it is. I mean, if it's really fascinating, but I think in the way it's taught in school, sometimes I think it's tough to pick up on it, because a lot of times it's taught by people who really don't, you know, who really don't treat these patients, you know, don't treat them, or treat them in a very limited point of view. And, you know, like the book will say, like, when you look at certain things, it'll say, if you have this, like, it'll be an arrow pointing up. If you have this, it'll be an arrow pointing down. No, people are people. Everything works differently. So I already made Tom feel bad for killing that patient. I'll tell you about my most embarrassing professional story, and then I'll tell you my best save and thing that I picked up. So outside of cardiac arrest. So the most embarrassing was, we had like an 86-year-old patient, and all of a sudden the guy's heart rate, I got called into the room. It says heart rate is 180. Okay. So like, oh man. So we see this guy, and we know at 80 years old, you don't want your heart rate at 180, right? So I call EMS. I'm like, all right, we need an ambulance here. We have a cardiac patient. He's 86. His heart rate's 180. Call ahead to the ER. We're sending a patient in. He's 86. His heart rate's 180. Okay. We're looking at him. And over the course of time, I check his pulse, and I'm like, doesn't feel like 180. It kind of feels like lub dub, lub dub, lub dub. And I look at his box, and I realize that his box that he's on is hooked up, or the box he's supposed to be on is hooked up to a 20-year-old who's doing a full max bicycle across the room. And I say, listen, you know, now I have to tell you something. I say, you want the bad news or the good news? The bad news is we obviously look like idiots because we have the wrong patient on the wrong box. The good news is you're okay. So, but then I had to call the doctors and call the ER and say, listen, we had the patient on the wrong box. Most embarrassing. Most interesting, one day Marion called me over, and a patient was sitting and his stomach was going, and she says, what do you think that is? And I said, I don't know. Let me look for a little bit. And I look at him, and sure enough, his stomach is going, and I check his pulse. And every time his stomach comes out, I feel a pulse. And he said that he had been to 2 doctors, and they told him that it was abdominal muscle spasm. And I called his doctor and I said, listen, I hate to tell you this, your patient's on the way to the emergency room. He doesn't have a spasm. What do you think it was?
Aortic aneurysm?
Mhm.
Nope.
No,
Oh, we had a lady today who had a pulsatile mass. Nope, it wasn't an aortic aneurysm. What it was his pacing wires had advanced and were now pacing his abdominals instead of his heart.
What? Really?
Yep. Yep.
Wow.
Once in a lifetime. So you probably won't never see it.
Is that a good way to get a 6-pack? Asking for a friend.
Yeah, he bought me some beer after that. So he bought me a 6-pack of Schlitz. Other questions, comments?
No, I have a question. So I was talking to someone today actually, and she's 30 something years old. She had COVID in March, and I figure you might know that if it's not appropriate, let me know. So she had COVID in March, and one of her symptoms was chest pain, chest discomfort, right? She's back to normal. Over the weekend, she had chest discomfort again. And today I was talking to her, she was telling me, oh, I checked my Apple Watch, everything, her heart rate's normal, but she's having that chest discomfort, and it doesn't matter what she's doing, she's having some tightness. Like, it's not, she's making an appointment with her doctor, but she can't get in until December.
Right.
And then she's not sure, should she go get a COVID test? Should she go urgent care?
So she had COVID already.
She had COVID already.
When?
In March.
So she's a long hauler, essentially. She might be a COVID long hauler. And the thing about, so when I said before that there's chest pain pre-COVID and there's chest pain post-COVID, so chest pain is one of the most common things that we hear from people. Now, when somebody who's 75 or 55 or, whatever reports chest pain, we think about an acute coronary syndrome, right? So we think, is having ischemia? Is this angina? Are they having a heart attack? The majority of patients with COVID that have chest pain, it's not an acute coronary syndrome, and we don't know exactly what's causing that chest pain. So they should be worked up. One of the interesting things is that the majority of patients that we see as long haulers got sick in either February, March, or April. And if you think about that, that was a time when people, especially young people, were being told shelter in place, right? Or you had 102 fever, you're not sick enough for the ER, right? So stay home. And we don't know what happened to these people as we went along, right? But it's not acute coronary insufficiency. Because COVID doesn't cause atherosclerosis. We did have one patient who did have an MI post-COVID, but he had an MI pre-COVID also, and he had a lot of risk factors. So I think if you're prone to heart disease or you have coronary insufficiency, I think that, COVID will definitely exploit that. However, in a situation like that, a lot of patients wind up testing normal. So patients will say, I have chest pain. They get an EKG. They say your EKG is normal. They don't even do enzymes because they say you're 37 years old. There's no way you're having a heart attack. But their EKG will be normal. And then they stop the testing there. So from a risk stratification perspective and the idea of addressing life threats, I like patients to have an EKG, at least a 24-hour Holter monitor, if not a 7-day or 14-day Holter monitor for arrhythmia, and also an echo, ideally a stress echo, because that is going to tell us, if you remember before when I spoke about risk stratification, the electrocardiogram and the Holter are going to tell us about the electrical activity of the heart and indirectly about the circulatory activity of the heart. The echo is going to tell us about the mechanical and indirectly the circulatory. So with a Holter monitor and a stress echo, then we have all 3 components covered. And if there's nothing there, then one of 2 things happen. They're having the sensation of chest pain due to autonomic dysfunction, or they are having a heart problem, but we don't have the technology to detect it yet. And it could be endocarditis. It could be myocarditis. It could be, pericarditis. It could be an effusion. So if she's only had an EKG, which is probably the case, she should have an echocardiogram, at least a resting, ideally a stress echo if she's young and fit. But that will at least be able to tell us about the cardiac structures and if there's inflammation in the heart.
Does that mean you don't see her until she gets those things?
It depends what you're seeing her for. So to me, the sooner the better on stuff like that. Like if you're seeing her for the back, or you're seeing her for a hip, or you're seeing her for something musculoskeletal, I wouldn't necessarily say I wouldn't see her, but I would say I'm definitely going to get close up and start taking vitals every session. And I'm going to start looking at position changes. And if that person, like if you ever have a patient who's in the clinic and they're having chest pain or pressure when you're there, call us. We'll get them hooked up right away. We had one of Rob's patients a couple of weeks ago who seemed to sort of pass out, and we'll get them hooked up. We'll look at their EKG, we'll check their blood pressure, check their vitals, and then we can determine what's going on here, because we don't want to guess. And again, especially we see people who, are older. We see people who have risk factors who may not have been worked up. Again, think about your patient with the chronic, hip pain who can't walk uphill, right? We all have patients who could tell us, I can't walk upstairs. They can map out the neighborhood by the hills, right? And they avoid those hills, or they know exactly where there's a place to sit down, or they know exactly where there's a public restroom where you don't have to buy something and you can still go to the bathroom, right? Those are the 4 things people look for in life. Get all those, you're in business. But think about that patient who does have a lot of risk factors, but maybe we don't know that she has coronary ischemia because she never pushes herself hard enough physically. So we see something quite the opposite, which is we used to see a lot of pulmonary patients who never would. And the other thing, think about that patient for how people get tested for heart disease, right? Stress test. So most of it is done on a treadmill. The majority of people will use what's, the Bruce protocol, which starts at 1.7 miles per hour, 10% incline. So if you think about your 80-year-old lady who's coming in with arthritis of the hip, that first 30 seconds would fling her across the room. So guess what? We get a stress test report that says patient did 37 seconds negative for ischemia. And then the patient believes that they've had their heart checked, but we never hit a hemodynamic endpoint, right? So the idea is we used to see pulmonary patients who their limiting factor was shortness of breath. So what happens sometimes is we'll see a patient, we'll teach them how to breathe better, we'll get them in shape. And then once they're in shape, then we find out they have heart disease because now all of a sudden they're able to do the activity that they weren't able to get tested for before, or they got tested and the test was stopped because of shortness of breath or lower extremity fatigue. And it's very rare that you'll see a doctor who is going to order a pharmacologic stress test in a patient who's not reporting symptoms. So we've been very lucky. I've been very lucky in the sense that I've had really great mentors over the years. My one mentor was named Dr. Mariano Ray, who was like a super brilliant cardiac diagnostician. And it's like, we really just taught me how to like flip things over in a million different ways and look at it from all different sides. But you don't want to make a mistake, and you want to be able to get to the heart of the problem, no pun intended. But, the idea is that sometimes patients come in and they think this is their problem and it's really something else, or they think this is or you've taken care of this problem and now we're able to see another problem because they're actually more fit. So we don't want to be like, your hip is cured, and they go. You want to just make sure that we're looking at the big picture. Other questions, comments?
This is back to the COVID thing. Can you see the autonomic whatever it
Function?
is, dysreflexia? Can you see that in somebody that had COVID 6 months after, where they didn't have any symptoms of it before?
If they didn't have any symptoms of dysautonomia, yes. So we've seen patients who present with very mild acute case of COVID, and then 6 months later, they have more symptoms or they have worsening symptoms. I haven't seen anybody that had an asymptomatic course. I haven't seen anybody that I know of that was asymptomatic during COVID, like didn't know they had COVID and then wound up as a long hauler. I've seen people with very mild disease who wind up as serious long haulers, but I don't think, or I'm forgetting, I can't recall anybody off the top of my head that was totally asymptomatic and then started developing symptoms, months later.
Are you not seeing as many long haulers in people that got it in July or August?
We're not. And I mean, first of all, July and August, I mean, they're long enough. That's long enough ago for them to be long haulers. But I think the big difference is that, first of all, at the very beginning, like if we think about New York City, first of all, the hospitals were super swamped, right? So you had to be like imminent, like you were going to die in the next couple of hours in order to get admitted. Everybody else was told shelter at home. People who were elderly, people who had pre-existing conditions like heart disease, respiratory disease, and diabetes and or obese, like these patients were often sent home. They were admitted, right, for fear of what might happen to them. The younger patients, the patients without pre-existing conditions, they were sent home. And like there's one patient in particular, we have a 20-year-old patient who Marion took care of for months and is still taking care of, who I'm sure Marion saved her life. And I'm sure if it was just freak chance that she was a friend of the family, and if Marion wasn't a friend of the family, then this 20-year-old girl probably would have died, because we found out later that she had tons of clots. And it's kind of like Ferris Bueller's Day Off, like when they drop the car off at the garage, and next thing you see the two garage attendants going out in his car. And like at the end of the day, like their car has been everywhere. Like we see patients 6 months later, we don't know what happened in those 6 months, right? And I think that my hope, and I hear people talk about this a lot, but not enough. My hope is that had these patients been admitted to the hospital where their blood pressure is going to be taken every hour, or what have you. Like if you see somebody and their pressure is 200 over 100, they're going to get an IV that's going to lower their pressure in 2 minutes. It's not like you're going to go home and try to breathe with it and, work your ass off not to die overnight. And a lot of people say to us, I didn't know if I was going to wake up the next day. I was afraid to go to sleep. So initially, we didn't know about the long hauler because it was a brand new disease, right? And then a lot of these patients, especially the young patients, felt like they were being gaslighted by the system, because as I said, they'd go to the hospital, EKG would be normal, chest x-ray would be clear. I'm short of breath. Your chest x-ray is clear though, go home, right? And your EKG is normal, you shouldn't be having chest pain, go home. And you're young and you're going to survive it and you're going to come through it in an easy way. The patients that we see that are long haulers, they're not people in their 60s, 70s, 80s, 90s, hundreds. They're people in their 30s, 40s, and 50s. And they're 80% women. Okay. And we know that women aren't listened to and taken as seriously by the medical system, right? In general, but with COVID, where you have a medical system that nobody has any experience with it, they're going in and doctors are kind of like, I'm going to base this on these last 50 years. And they didn't know anything. So they had a hard time even being taken seriously, even they'd be told, oh, you don't have COVID, or they'd be told you're anxious. They'd be saying, like, have you thought about seeing a therapist? And so for these patients that are, 6 months in, maybe if they were admitted to the hospital, put on blood thinners right away, put on steroids right away to reduce inflammation, given remdesivir, and that's where I think, from a big perspective globally, like what we have to do is we have to take people seriously who are reporting symptoms. They have to at least come into the hospital for an evaluation, because maybe you don't need to be admitted, but maybe you could be put on baby aspirin and given some prednisone and given, something that will prevent you from becoming a long hauler. So if that happens, then that means over time, we should see less and less long haulers. We don't know what's going to happen to the people who are initially long haulers. And we are starting to see improvements in people, some of them 6 or 7 months in. 7 months in seems to be kind of like the magic number for a lot of the serious long haulers. But, this is the case for for wearing a mask. This is the case for social distancing. This is the case for prevention, because guess what? If the hospitals are only full of the most serious cases, then people are going to become long haulers because they're not even going to be able to get seen. Catherine.
No, does direct access work for a pulmonary rehab post-COVID?
Is there what?
Direct access? Do they need a doctor's prescription?
No, there's direct access, but you know, to me, I don't know. I've never felt like direct access was something I wanted to fight for. And I don't even care about direct access. And the reason why I say that is because a patient comes in, like for all the reasons we're talking about, right? Like, so what? I could see you off the street. And what if you have a pulsatile mass in your abdomen that I missed and you have a dissecting aortic aneurysm? I like working with doctors. Okay, I've never felt competitive with doctors. I've never felt like, well, I'm a physical therapist. That's why I have a doctorate. Make sure you call me Dr. Greenspan. You know what I mean? Like, I know some physical therapists that if you made it illegal, they'd be doing heart surgery on the plinth, like in the middle of H&D. I don't care about that. And as a matter of fact, from both a clinical perspective and a marketing perspective, when I see a patient, I want their doctor involved. I send a letter to their internist. I send a letter to their cardiologist. I send a letter to their pulmonologist so that, you know, as things are going along, I don't call them up and say, hey, by the way, did you know that your patient, blah, 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 blah. Go, who is this? Go, I didn't even know my patient was in pulmonary rehab, right? So you say you want the team involved. Like, you know, PTs, sometimes we get a little bit of a big head, not as big as RTs. RTs are the worst. They're the ones that are like, we're heroes, you know, but PTs also, like, stay in the lane. It's okay. We could do a ton as PTs. We could do a ton as PTs. Direct access to me is not a benefit because I don't want a surprise. I want to be able to communicate with the healthcare team. I want to be able to get scans. I want to be able to see tests and be a part of it. Trust me, doctors love us because guess what? They see a patient for 10 minutes. We see a patient for 3 hours a week under fully monitored conditions doing the exact things that elicit symptoms. So we've caught stuff over the years. We probably caught, I mean, hundreds of things. You know, we've sent 100 patients into the ER over 100,000 visits, right? So 1 in 1,000 patients we send into the ER. And if we weren't doing the monitoring, we never would have known it and we never would have caught it. And maybe that 86-year-old patient would have gone home and died in their sleep. And everybody would have said natural causes when it was really something that if we were paying attention, we could have caught. Right. And that's where, you know, everybody said to us when we opened, why do you need EKGs? These are pulmonary patients. And we're like, yeah, but in the 100 patients that we sent to the ER, 95 of them we caught because something was on the EKG. Patient was asymptomatic, right? We just happened to get lucky that we had an EKG on them. But the more you look, the more you see. It's like testing, right? It's not like the more you look, the more you make problems, the more you pick up problems. It's another Republican joke there. It was subtle. For those of you that are still at H&D, I would recommend at this point, just stay there till morning, start working in a couple of hours. Other questions, comments. So we're happy to do this. I'm happy to do this every Monday for a while. I'm happy to get people up to speed. That's what we want. You know, again, we don't want to be here for 6 months and then Rob and Greg are like, those motherfuckers, why did we pay them? They came here and they didn't do shit while we were here. We'd like to leave with all you guys like up to speed and really better physical therapists for it. Because trust me, when you start catching stuff and you start looking at not just the musculoskeletal or the neurologic, but you start to see these systemic activities and you say, something's not right here. This doesn't look like something local. This is systemic. It's a fascinating area of rehab. And like I said, there's 65 patients waiting to be treated at this moment. So, you know, there's a lot of, and heart disease isn't going away and COVID, we hope is going to go away, but there's still going to be, you know, there's still going to be patients to see. And, you know, just even in terms of your own confidence level, you could be on the bus and you see somebody and you're like, that doesn't look right. Pick it up, you know. I learned more in my first year or equal. I learned more in my first year of EMS as I did or equal in my first year of EMS as my first 7 years as a physical therapist. But that emergency stuff just really was like the glue that holds it all together. And, you know, the more you do things, the more confident you get with them, the more skilled, the easier you recognize things. You know, we could very easily get caught in a bubble. You know what I mean? We could be very easily get caught at only looking at one thing. And it could be something totally different. So there's going to be a couple of more anatomy things that we have to get through. Otherwise, you know, the other stuff won't make sense, but then we're going to get super clinical with it, and we'll do case studies. And if you guys have cases, like Greg brought me a very interesting patient recently. Today, Alita asked me about certain things that I thought are very interesting and potentially, you know, cardiopulmonary in nature. And, you know, think about how great would the practice be if after you relieve their pain, well, now we could tune them up and make them like athletes again, you know? And it's great because then they leave and like, I have my life back again, you know? And if it's not one thing, it's the other. There's a reason why old people say that all the time. It's because once their hip gets better, no, I'm just kidding. But it's like, you know, the idea is like, it really changes your entire scope of practice, and it really changes what you have to offer people and how you can really positively impact their lives.
Thank you. Thank you. It was awesome.
You're welcome.
I'm hungry for more every time I hear. I just want to learn more. I have one more question, but I know we're running out of
Go for it.
time. But I feel this could be basic, so I apologize if I'm insulting. But cardiac output equals heart rate times stroke volume.
Right.
I know how to measure heart rate. How do you measure stroke volume?
So echocardiogram.
Is that what it is? Okay.
Yeah. So, and I'll just tell you, I'll give you another formula. That's a great formula. It's a terrific formula. It's a terrific formula. No one has ever seen a formula like this before. I've heard that this formula is really terrific. But if you want to, and everyone knows what ejection fraction is. What is ejection fraction? Someone tell me clearly, please.
It's the amount of blood that's in the ventricle that's ejected or remains in the ventricle after the diastolic contraction. No.
You were almost there. I thought you were going to park the car and then you smashed the one behind you. So I thought you were good. I thought you had a one move park, but then you were like, you were close. But we talked about some of these things already tonight. So remember LVEDV, right? Left ventricular end diastolic volume. So that's the amount of blood in the heart at the end of filling. That's the denominator. Stroke volume is the numerator, right? So stroke volume over the end diastolic volume. So it's what percentage? It's the fraction of blood that's ejected of the blood that could be ejected, right? So of the blood
that's what I was trying to say.
You did say it after like you had a Malachi crunch with the first two cars, like, you know, and a free copy of my book to anyone. And I know Greg knows what the Malachi crunch is. Do you?
Yes, of course. Happy days.
Happy days. Yeah, I knew you knew it immediately. That's right. When they were in the demolition derby with Fonzie and Heather Tuscadero. Leather Tuscadero.
Oh, leather,
Tuscadero. Pinky Tuscadero. But the idea is, one of the ways, like when we look at an echo, one of the things we look at is ejection fraction, right? So normal ejection fraction, it's not 100%, it's 55 to 75%. But as somebody develops heart failure, what that's telling you is they can't pump. So they have a lower ejection fraction. So it's like the beauty and fun of cardiovascular physiology plus math. Like what could be better than that? Like think about it. All right. So I sent you the slides, Greg. So everybody should have these slides.
Yep.
I'll send out the slides ahead of time so you could study, Tom, so we don't have an accident like that again before next week. No, I'm kidding. I knew you were going to get there. I just don't have time for that. I didn't have all night to wait for you to come around the bend. But I'll send the stuff out ahead of time next week. And again, you know, the best way to learn this stuff is clinical cases. So if you have cases that you think are, you know, let's talk about them, let's chop them up, and let's, you know, look at them from all different sides and see what can we learn and what can we teach. Last minute questions, comments, feedback.
I'll have a question. I know I'm covering one of Pat and Rob's patients tomorrow, and Jay Goldsmith, I believe. So I read his history, and I'm thinking, I'll talk to him about it. I'll talk to you about it after tomorrow. So,
And another thing just to think about, like when we talk about these different abnormalities, right? And we talk about venous return and, left ventricular dysfunction and things like, sometimes even position, position is enough to kind of set somebody off, right? Because if you think about it, you put somebody, how many times do you put somebody with their legs up in the air, right? Think about the impact on the cardiovascular system. We get a ton of venous return, increases the workload on the left ventricle. And if that person is prone to heart disease or heart failure, or they have coronary insufficiency, that could be enough to kind of put them over the edge. So, we have to think about these things. It's all connected. And, it's good to have a nice, shiny titanium knee, but if your motor doesn't work, you can't go anywhere. So, but you need all, I'm just kidding. I like to make jokes about orthopedic therapists, but no, I'm just kidding. But anyway, but again, we're there in the practice. It doesn't have to just be me. Marion and I have been working together for 26 years. So if I told her everything I know except for one thing, which I'm waiting till I'm on my deathbed and then I'm going to tell her. But and Wei is great at this stuff. He's a super exercise tester. He really understands the physiology, and we all want to teach you guys. So if there's stuff there and we want to learn, I was watching Allison today with one of our COVID patients. It was fascinating to me. It was really fascinating. So, I feel like I might have missed out on 30 years of musculoskeletal work, but, I guess I'm gonna have to do it next lifetime. But again, ask us. We're happy to help you guys. We're happy to consult on cases. And, we're not reopening the pulmonary center. So, it's one of the things where, we want to leave patients in good hands. And you guys are in a really unique position to take it over and to build a beautiful cardiopulmonary center. And it's possible. It's possible to be done. So I hope that, we can all take advantage of this time and really get the most out of it.
Noah,
thank you.
Yes.
Rosebud.
It's not Rosebud. It's not Rosebud. No, there's something very important I have to tell you, but I'm waiting till I'm on my deathbed. Rosebud. You're gonna rethink a lot of things for the past 26 years.
The Rosebud
Have a great
Hotel?
night, everybody. What's that?
The Rosebud Hotel? What is that?
No, that's what movie is that? The
Citizen
Citizen
Kane.
Kane.
Citizen Kane.
Yeah,
Oh.
Citizen Kane.
I was
Person has
watching
a
too much
sentimental-
Schitt's Creek, I guess.
It's like Bosco. Greg, if we said Bosco, you'd know what it was, right?
Yeah, of course.
What is it?
That's it's a Donnie Bosco.
No.
That's Brasco.
Think Steinfeld.
Oh,
Wait, give Greg
Seinfeld.
give Greg
Think
another chance.
Seinfeld. Think Seinfeld.
Oh my gosh. All right, it's stumping me.
It's George Costanza's ATM code.
Don't you all go run into the bank now.
That's good.
All right, have a great night, everybody. And again, we're there. Use us up, please. We're happy to help you.
Thank you. And thank
All right,
you
have
all
a
for
good night,
taking
everybody.
time on.
And I have a video on this, so I'll make it available as well.
Great.
Thank you, Noah.
Thank you,
All
Noah.
right, guys, have a good night.
Good night,
Bye-bye.
guys.
Good night. Good night.